Hello, I'm Dr. John Kruse, and welcome to this week's question and answer hour. So I'll be trying to answer questions about the video released this past week, about ADHD in general, and any other mental health or even broader questions that come in. As usual, the comments here are intended for informational purposes only, so I'm not making specific medication recommendations. There is a subreddit for those who want to engage in longer conversations or questions. And there were some questions hanging over from the end at last time. So I will try to get to those before I answer the questions that have already come in. And but first, I will do the review of the video that was released this past week. So the video that was released was about a new way of neurofeedback. So I do have an older video on neurofeedback done about 2.5 years ago, where I summarized that despite 50, 60 years of using EEG based neurofeedback for treating ADHD and other conditions, the research data supporting that it's effective is extraordinarily weak. And at the time I did that last video, there had been a large, very well controlled study essentially showing no clear benefit from EEG feedback. Since there have been two meta-analyses that came to pretty much the same conclusion. One of them was a little more generous, saying that the results are so inconsistent that maybe some of these particular approaches were helpful, but we need more replication. So the new video is not specifically on EEG feedback for ADHD. It was a study done out of China using EEG-based neurofeedback for treating methamphetamine abuse, which is hard to treat. We don't have any medications yet that can treat it effectively. And they did two things that were different than most other feedback EEG studies. One is that they individualized treatment for each person, got a different specific individualized treatment rather than everybody just trying to change the theta beta ratio or something like that. The second was that rather than looking at a specific region or a specific brain waves, they took a composite of total brain activity when people were exposed to methamphetamine cues, and they were trained to suppress that activity, which they learned to successfully do. And then they were offered visual cues that trigger methamphetamine craving, and those visual cues no longer triggered craving, which was a powerful effect because all previous research has indicated that craving when seeing cues is a very strong predictor for ongoing or continued methamphetamine abuse. So the downside, there was no real world. These were all inpatient rehab setting. There was no post rehab. How well did these people do? But there's the same group has gotten similar effects using a individualized and whole brain approach for nicotine abuse treatment, showing it to be effective. And there's even a few studies from EEG feedback, neurofeedback, looking at depression, where a side finding of these studies was that targeted treatment wasn't as effective as looking at what happened to the overall brain activity pattern. So the study has bigger implications than just EEG feedback or using EEG. The study is suggesting that even though we know there's certain addiction pathways and expectation pathways, and it's not saying those are unimportant, but it's saying that the whole individual constellation, that each person who has ADHD or depression or schizophrenia or methamphetamine abuse is at least partly getting there by somewhat different pathways than anyone else in the world. Their brain is unique. It's them. Again, there may be some commonalities, but it was more powerful to treat the whole brain approach than to, again, treat specific pathways or targeted regions. So that has, I think, implications for all of mental health research. So that is what I will say there. Hopefully it will open up questions. So the two questions that were left over last week, and hopefully our internet connection continues well this week. So Dylan asked, do I do counseling as well as medication management? And the answer is yes, I do talking therapy, psychotherapy, and specifically for people with ADHD. I've done in the past some group CBT, but more often individual CBT based treatment. I should say the broader comment is that since moving to Hawaii in 2022, I'm not taking any new patients. So I'm trying to spend more time using what I've learned and what my patients have taught me to help a broader range of people through my videos and writing. So the second question was from Hesham Atia, and sorry if I'm mispronouncing the name. And they had been on a combination of Prozac and Strattera, if I read it correctly. So Prozac, a serotonin reuptake inhibitor, Strattera, a norepinephrine reuptake inhibitor. And then they were switched from the Prozac to Cymbalta, duloxetine, a dual serotonin norepinephrine reuptake inhibitor, still maintaining the Strattera. And they had noticed there was an increase in heart rate, more trouble sleeping, and I think maybe other side effects. And they were wondering if this was an indication of too much noradrenergic activity. And I'd say that's, to me, the likeliest explanation. So even though in both scenarios we're essentially playing with serotonin and norepinephrine reuptake, um, we're just juggling probably the relative amounts. There are some people who are exquisitely sensitive. So it bothers me when formularies for insurance plans or pharmacists tell people, oh, Effexor, venlafaxine, Cymbalta, duloxetine, Vetsima, milnacipran, oh, they're all serotonin norepinephrine reuptake inhibitors. Therefore, they're all interchangeable. But we know that Effexor, venlafaxine, at its until you're above 100 milligrams, it has almost no noradrenergic activity. It's primarily a serotonin reuptake actor. Duloxetine's relatively balanced between the two, and milnacipran is probably stronger on norepinephrine than serotonin. Now, many individuals feel the same or are equally well treated for depression, anxiety among the three of them. But I've had some people who felt numbed out, sort of emotionally numbed, lethargic, not outright sedated on Cymbalta, and who felt too revved up on Vetsima. So I've had several patients over the years where it was actually a combination, so something in between Vetsima and Cymbalta was the perfect combination to them because too much Vetsima, they were too buzzy, too revved up, too agitated, and again, too much on the serotonin side. They felt too numb, too flattened out, too locked in. Um, so some people are exquisitely sensitive to that balance. The other possible explanation is that many people on any new drug, regardless of its specific mechanism of action, their body is picking up information. They're getting new side effects or sensations, and that can feed into a panic-like loop. So I talk about that in my video on panic. So it's possible that it isn't a specific mechanism of action, but that it was just something brand new and the body's reacting with a sympathetic overdrive reaction. So that would be my potential explanations there. So on to questions for today. Jack, hello. Rick Roll, hello again. Rick asks, for someone who doesn't tolerate stimulants because of PTSD and ASD, do you use, or do I see guanfacine and memantine potentially being a good combination? Would combining them together have greater benefit from one med alone? So those are both medications used for ADHD when stimulants aren't tolerable. As far as we can tell, they are probably having separate mechanisms of action, with guanfacine having effects on a specific subset of the norepinephrine system that's having feedback loops, causing dampening down of parts of the norepinephrine system and slowly causing synaptogenesis in the prefrontal cortex. And slowly, as over the course of several weeks, memantine's thought primarily to have glutamate blocking action. Um, so there is a logic to combining the two. What I would always recommend in general is only making one change or starting one drug at a time. And given that guanfacine takes a long time to start acting, I would probably wait at least 6 or 8 weeks after starting guanfacine to be adding memantine, if that's the sequence you opt for, um, or someone opts for theoretically. Hello, Max. Max asks, when sedatives and stimulants are prescribed at the same time, why don't they just cancel each other out, especially ones that work on the same neurotransmitter, for example, aripiprazole, Abilify, and Ritalin? So, two different aspects of the question. One is usually when they're prescribed together, they're prescribed for different times of day. So, it's that someone's using stimulants to be either more alert or more focused during the daytime and using sedative agents, benzodiazepines, or others at the end of the day to damp down, to shut off that possible sympathetic overdrive. So, most of the time, so it's taking Ativan in the evening or Valium in the evening, even though Valium has a long half life of about 24 hours. So some of it is continuing on. So even with moderately short lived stimulants and sedatives, I'd say the establishment, psychiatric establishment sort of frowns on that practice because it's sort of you're chasing uppers with downers or downers with uppers. And I get that philosophically it's not a good thing to do, but I actually have seen a handful of people who came to me usually on such regimens and swore by it and did not function as well when either component was pulled away. So I think there are a small segment of people that this is a reasonable compromise or the best way for them to manage their mental health conditions or their own neurochemistry. So I would agree that giving those two types of agents at the same time generally isn't a good practice. I mean, there are some people who feel they can't tolerate even low doses of stimulants unless they're on a benzodiazepine. Again, those are benzodiazepines are thought primarily to be working on GABA systems. So that would be working on two different systems. And I do have a video on Abilify and Risperidol for ADHD, so antipsychotics, I think is the title of it. So the common conception that antipsychotics are dopamine boosters, dopamine blockers. ADHD medications are dopamine boosters, and they're working against each other has a couple problems. One is that the first generation of antipsychotics, so things like aldolthorazine, um, profenazine, those primarily were dopamine 2 blockers. So those maybe more directly are in opposition to stimulants, whereas many of the newer second generation things like aripiprazole are more accurately thought of as dopamine modulating agents. So they're when levels are too low, they're kind of boosting them, and when levels are too high, they're preventing them from getting too high. That's an oversimplification itself. And there's also differences between the acute effects, and dopamine release is both tonic and phasic. So there's immediate sort of pulsatile short-term release, and there's more chronic ongoing um, secretion. And the tonic release actually has feedback implications for the phasic release. So the simple answer is that we're not usually talking that both, and even with Ritalin and stimulants, where our immediate direct effect is to reuptake block the reuptake and make more dopamine available at the receptor, or not make it not more of it, but make it available longer so the signal can be stronger. That itself has feedback loop implications. So both of these may be more dopamine modulating or regulating than just up blocking or boosting, is the simple answer. So James Alexander asks, for those who do gain permanent tolerance to stimulants or antidepressants, what are the possible explanations on a cellular neurochemical level for what is happening there? So one is, I am not sure we have complete consensus. The really shorthand, simplifying a lot and overgeneralizing a lot, is that exposure at the neurotransmitter at a synapse leads to potential up or down regulation, where the cell is, because it's exposed to too much or too little of a certain neurochemical, is then changing how many receptors it's making to respond to that, either pushing out many more or not making many at all, so it's not overly sensitized. Um, it's a good question. I guess I'll just stop it there because I don't have a more detailed, descriptive cellular explanation. So Max is also adding a link to, I was interviewed on a Scottish um, mental health, cognitive health podcast last week. It's called the Struggle Podcast, and it's out on YouTube now. So sorry, jumping around a little bit. So hello, Dennis. Dennis asks, why aren't stimulants used for depression more often? So one is, and I have talked and written about hive mind among doctors. Even though doctors have some scientific training, so when I went through MD PhD training, one is there were some schools that sort of merged or blended the two degrees, and I think diluted both of them. I think they're fundamentally different ways of thinking, and one of my flippant ways of summarizing it is a PhD wants to be the first person to do something. You want to be discovering something new, you want to be creating new knowledge, you want to be opening new doors, and a doctor wants to be the second person doing something. Because if you're the first person, you don't know, is it really going to work? Are you endangering lives? Are you harming people? So there's a lot of along the lines of do no harm, and maybe some of it's also cover your ass. In this day of, particularly in the US, lawsuits for anything that might deviate from the standard, you could get sued for. So doctors do what other doctors do, and also they do what they learned in training. So if they weren't exposed to it in training, the likelihood they'll pick it up later on in their career is low, not impossible. So part of it, when I was in training, which was in the 90s for residency in psychiatry, um, particularly on the consult liaison psychiatry services, they exposed us to studies and research showing that stimulants, particularly Ritalin, yeah, but amphetamine products as well, had a number of studies showing they were effective for depression. But all the papers cautioned and all the dogma at the time was these work. And not only do they work really quickly. So unlike the tricyclics or the early age of the SSRI sun, which took several days to a few weeks to work, stimulants tend to work within a day or two. Um, and it doesn't just seem to be by creating a euphoric effect. They do seem to reduce a multitude of symptoms of depression. But it was concluded that the addiction for potential was so great that the only people in the hospital with depression who should get them are people who are dying of cancer. Because if you're dying of cancer and you're going to be dead anyway, then we don't have to worry about addiction. that was essentially the message that was put out. That's not a very, okay, I know that the stimulants work, but I'll wait till my patient gets cancer and then I feel safe or comfortable giving them stimulants. I'm being a little flippant again, but that's, I think, the popular mindset. And I think I've seen subsequent generations of psychiatrists who are trained who aren't even aware of the studies that were done in the 60s, 70s showing that these are good and effective antidepressants. And why part of why I say that is about a decade, maybe it's 12 or 15 years ago now, when we started doing research on ketamine, virtually every article in the popular press or in scientific psychiatric journals would say, ketamine, this is the first thing we have that quickly treats depression. Ketamine's a breakthrough because it's the only thing we have that immediately treats depression. Ketamine stands out from everything tried before for depression. It was complete bullshit. Because again, there were many studies showing stimulants worked quickly, but that had been sort of repressed, forgotten, neglected in the field. So again, I would argue, the risk for psychosis, the risk for addiction is present there. And it seems if it's present at all with our standard antidepressants, those side effects are much, much, much less common than they are with the stimulants. That's a reason to be cautious, but particularly when people have treatment resistant depression or standard medications don't work, I think more often we should be looking at augmenting or treating with stimulants. So I didn't read the follow-up or connection. So Dennis points out that stimulants increase norepinephrine and dopamine by blocking their reuptake, which is similar to bupropion. You would imagine that since bupropion can work for depression, then stimulants could work as well. So yes, the basic science suggests they work. The clinical research data indicates, yes, they work. So James Alexander is following up on one of the last Q&As, is asking, did I say that I probably should have been so James, so I in the previous talk I mentioned, so my younger brother at the age of 58, and he was healthy. He was a competitive ultimate frisbee player. He carried a little more weight on his body than I do, but had regular checkups, including cardiac checkups, and age of 58 died abruptly shoveling snow, um, shoveling a stranger's car out in an ice storm in Portland, Oregon. The guy tried to revive him. The ambulance was there within minutes. They tried to revive him. Well, he was dead immediately. Whether that's a good way to go or not, we can debate that separately. Anyway, my cholesterol had been above 220 for decades, since at least medical school. And every time I saw a primary care doctor, so both blood pressure and cholesterol were elevated. And they would say, well, you're a marathon runner, you eat well, you're fairly calm, and you're not smoking or using other drugs or doing all the lifestyle things. So why would we treat this? And my point was, I am doing all the lifestyle things. I am exactly the person you should be treating because we know these high blood pressure and elevated cholesterol are risk factors for cardiovascular, say, deterioration and damage and long-term health or severe problems. So I think if the numbers indicate, and I don't know, and again, there's discussions on whether total cholesterol is most important or LDL to HDL ratios or other LDL itself or separate, even narrower fractions of the cholesterol picture. But I mean, essentially, people are taking cholesterol medication as a preventative measure. So I would sort of question the other thing. I've often seen 80-year-olds on cholesterol lowering medications. again, most of the benefits they have are long-term, delayed over time effects. Does it really make sense to be continuing those medicines at 80 or 90? So it is the young or middle age, depending on where we put the definitions of. I think the statistics indicate um, those are the people who should be on it. Are we pushing them maybe for reasons, or are more people on them than need to be? I'd say the epidemiologists are divided or conflicted there because health outcomes, numerous very large studies indicate that these are having both blood pressure medications and cholesterol lowering medications seem to be having benefits for long-term cardiac health, maybe for brain health, that seem to be in excess of just simply what we would expect by lowering the blood pressure or lowering the cholesterol number. So whether it's effects on other systems or whether it's more intricate effects on those systems, um, I don't know, but that's that's what I would say there. So Max is forwarding a question from Reddit by Dakwana, who was on lithium for 3 years and developed postprandial hypoglycemia. After discontinuing lithium, things improved, but still have minor issues that were not there before beginning lithium. And when I was out there with this experience, any ideas in general about why this occurred? So one is that, to my knowledge, I mean, lithium use has strong association with long-term renal kidney damage, clear association with thyroid problems, clear association with white blood cell issues. So I'm not aware of a strong and robust connection specifically with hypoglycemia, but many of our psychiatric medications, particularly antipsychotics, but others, do seem to increase the likelihood for what they call metabolic syndrome. So, where people are processing fats and sugars differently. But to back up half a step, mental health conditions in general, depression, ADHD, a whole host, schizophrenia, even with among individuals who have never been medicated for those conditions, have an increased likelihood for what they call metabolic syndrome. Again, that's how your body processes sugars and fats, and higher rates of diabetes, higher rates of obesity, at least with modern Western diets. So, I mean, part of why we do research is that for one individual, it could be hard to sort out. Was this really the lithium that had an effect, or was it really you started it at a time in life when people who had either your genetic or early lifestyle or other predispositions are likely to start getting more metabolic problems or issues? Um, so again, from one person, it can be difficult to be, even though the individual or their own doctors might be quite sure this caused this. That's why we need to do studies, because there are certainly other people who might have developed that with similar timing where it was more due to their age and what was going on with their known genetics rather than exposure to the lithium. So Scooty's 1983 says the recent research on amlodipine seems to point to the benefits of reducing hyperactivity, but are there any known benefits to the inattentive features of ADHD? So there's a couple different questions in there. I mean, amlodipine studies, the one I talked about in the video, I mean, they were using hyperactivity in rats and zebrafinch and many other research studies as well as a marker or as a model of ADHD. That doesn't necessarily implicate that hyperactivity is a important target of those agent, either the traditional stimulants or um, so so that's where I would start out by answering, and the follow-up or second question, but are there any known benefits to the inattentive features of ADHD? So, I mean, when people talk about their ADHD superpowers, what I hear people talking about more often is creativity, spontaneity, high energy, and enthusiasm. They're not usually um, discussing inattentive features. Um, if we're taking a neurodiversity approach rather than a disease model, um, the question would be, again, what are the advantages or what situations are a better match for an inattentive person? And I'd say part of what tends to be misleading is we're labeling that subtype or that collection of symptoms inattentive, whereas inattentiveness is only one of those symptoms. And again, just as ADHD is not a deficit of attention, it's not that people have no ability to pay attention. So one question is hyper focus, which we might be more appropriately labeling both inattention and hyperfocus as discontrol over attention. So you have less ability maybe to direct it where you want it, but when you get locked on, you have less ability to remove yourself from it. So I'd say in that way, I would view hyperfocus as possibly a feature of inattentive ADHD, even though it sounds oxymoronic to do so because they're both tied to dysregulation of her control. Um, s- so off the top of my head, I'm not clearly thinking of other advantages or situations that would be advantageous for many of the inattentive symptoms of ADHD, but maybe others can chime in while I'm not thinking quickly on my feet right now. So James Alexander is also following up from the last Q&A that if I've learned more important, meaningful things from performing psychotherapy on others than receiving it, what have you learned from your years of performing psychotherapy? Yeah, I'd say some of that is probably maybe more personal than I'm comfortable sharing. I think part of it is we each grow up in our own families, and even though we can identify some of what's eventually, as we interact with more people, some of what's unusual or uncommon, but I could say there's can be different levels of awareness and regarding what's really probably on the other side of the normal line for different forms of neglect and or abuse. I'll say one thing I'm more comfortable sharing. It's more so I've always tended to be quiet, particularly in a group situation. And one of the things I became much more aware of is one on one, or maybe this feels like a one on one situation. I can converse at length. I can, but in settings of two or more people, almost invariably, I am just sitting passively listening. Um, I'm not even remembering when I that became sort of crystal clear as a pattern, but it did. And I know some of the family constellations that I think are responsible for that, but realizing how severe that was, or how, yeah, what a severe difference in behavior I displayed in those different situations. That's what's coming to the top of my mind as things that are comfortable to be shared here. So thanks, Max, for providing the link to the video on antipsychotics and ADHD. Um, I'm having trouble. The names are written in gray, so it's harder for me to. Hello, Mr. Yarabandi is a 36-year-old guy with ADHD. And he sadly learned how to misuse some ADHD drugs, trying to enter a new path. Bupropion was very helpful after listening. Um, and he also brings up wine, and I'm not quite clear that my recommendation for most people dealing with mental health issues, but most strongly, particularly with depression, is even most people consider moderate amounts of alcohol are probably too much. The more we look, is alcohol is not your friend and not your brain's friend. So I'm glad bupropion's been helpful to you. And yes, it does highlight that there are real life situations, people, individuals who stimulants are not a good fit for them. So ultra paradoxical is thanking me for continuing to offer these question and answer sessions. Um, so you're welcome. Glad you could show up today. So Mr. Yarabandi is discussing that some incident, not clear what triggered it, while he was on Wellbutrin, um, resulted in breaking a brand new dishwasher and breaking doors on parents' closet wardrobe. Um, I'd say usually bupropion isn't associated with aggressive actions. If the dose is too high, I've seen some people who felt both more agitated and aggressive with it. Yeah. So when we talk about stimulants having the biggest effect, that does not mean that for everyone they have the biggest effect. It means as we generalize across groups of individuals with ADHD, they are the substance or the treatment with the largest success rate and the largest extent of symptom reduction. But that doesn't mean for everyone they are the best or most powerful treatment. So hopefully you can find other solutions. And I have not heard things like guanfacine being associated with any outbursts or aggression, or to me what sounds like sympathetic nervous system overdrive. James Alexander asks, do I believe complex PTSD is real? Have you ever had patients who have claimed to have it? How did they present and what were the course of their symptoms? Um, Good question. So I do have a video on trauma. Is it all trauma? Is it all? So officially in the DSM, we don't yet have complex PTSD. I think it's referred to. The people who don't like it feel that the definition of PTSD gets extended or broadened so much that almost anything can be considered a trigger or stimulus or a trauma, and that renders the term trauma meaningless. On the other hand, do I think I've interacted with people who had less than life threatening or loss of limb threatening experiences, particularly repetitive ones that were profoundly um, disturbing and maybe even disabling? Yes. Um, yeah, so I've certainly seen lots and lots of people who claim to have it. I think particularly when we're here largely talking about ADHD, and I've spoken about this before, but I am strongly opposed to much of what Gabor Mate proclaims and teaches. So Gabor Mate, a Hungarian Canadian um, family practice doctor, not a psychiatrist by training, has written very powerful books about ADHD, which he attributes in many of his claims as due entirely to trauma or traumatic mismatch between bad parenting on the mother, usually mother's part, and what the kid needs, and that's traumatic. So, can PTSD affect prefrontal cortical executive functions? Absolutely. Can there be extensive overlap? Absolutely. So, in my first book, and I think I mentioned it or as an anecdote again in the second book, I mean, in one example, years ago, I worked with a woman who was worked for 12 years with a psychiatrist who was primarily a psychotherapist, searching for what was the underlying trauma for all of her PTSD behavior. And the PTSD behaviors were not turning in her work for her job on time, not taking care of the paperwork for her job, showing up late for her daughter's performances, or even picking her up for school. So, time management issues, organization issues, um, blurting things out in group meetings and on supervisory meetings. It was a host of inattentive and impulsive hyperactive ADHD symptoms. It was straightforward ADHD. And the kicker was, despite 12 years, this woman had never figured out why she was, quote, self sabotaging herself because she grew up in an idyllic middle mid-income family, loving parents, supportive sibling. There were no major losses, deaths, failures in school, or physical problems. Um, so the woman presented, there was some depressive episode that her therapist referred her to me. And when I was evaluating the depression, said, this to me looks completely like ADHD. And if you haven't found any trauma, why are we attributing all of these behaviors to some trauma and self sabotage? And I had a few sessions, and her depression responded to an antidepressant, but all these ADHD symptoms persisted. And I think intellectually, the patient got, okay, this made sense, but they were, and I will use the term enmeshed. So they had a good, positive, nurturing relationship with their therapist, psychiatrist, and they were so wedded, both the patient now, but I mean, clearly the therapist, wedded to this belief that there was still some trauma that needed to be uncovered. And I don't think it was a therapist wasn't doing it because they needed the money, they needed the patients, they needed to lock someone in. I don't think they were doing it for their secondary gain, as it's called. I think they were genuinely did not understand and couldn't see ADHD when it was there, and therefore blame things on trauma. So there are certainly people who I would argue have been traumatized by the trauma industry, which professes that almost everyone is mired in trauma from abusive relationships, so or physical abuse. So Max, thanks for providing the link to the ketamine for ADHD video. Um, you're welcome, Dennis. And so ultra paradoxical, am I aware of any good work about the medical history of ADHD? I'm trying to remember any specific sources or I mean, I think there's bad sources. So ADHD Nation, I'm forgetting who wrote it. It's sort of a screed against ADHD by a New York Times former writer. I think presents a bias and under the lens that this is all the product of big bad pharmaceuticals. Um, I'm not recalling specifically, but Gina Pera, who wrote "Is It You, Me, or Adult ADHD," and has a good blog on it. I mean, she's by training a reporter herself. So if she's written, and again, I can't specifically remember if she has, I would trust that she has a fairly balanced and accurate history of it. I mean, I've certainly read reports and papers and articles that I think gave me some reasonable understanding, but I don't know what those references are off the top of my head. So sorry. I will think about that, and if I come across it, I'll, I guess, shout it out next week. James Alexander watched my Kelbry video and asked me to explain in more detail what is what being a serotonin modulating agent means. Does it boost serotonin levels on net? Do you think its agonism, antagonism of different serotonin receptors meaningful impacts its ADHD symptom relief in comparison to the serotonergic effects of other drugs like Cymbalta? So I'd say other drugs like Cymbalta or the pure serotonin reuptake inhibitors, and fairly cleanly, specifically, we know block the SERT, serotonin transporter molecule. Again, allow serotonin to last a longer time at the synaptic ending. They're not boosting serotonin by making more of it. They're not releasing more of it, but they're allowing more of the signal to be there. So I have not been, there may well have been papers written about Kelbry since I've did the video, but I haven't seen them. So I can't give you more detail and more specifics because to my reading, it was sort of hand waving, and sort of one study is showing that I think it was serotonin. No, I'm going to be speculating, so I shouldn't speculate. Whatever subtypes of serotonin receptor. So it wasn't a simple serotonin reuptake inhibitor. It was having effects on some subsets of the serotonin system. And again, not a lot of that had been replicated. And it was not clear at all how this was modulating either norepinephrine systems or even what the net output of serotonin systems is or was. So there may well be people, particularly at Kelbry headquarters, who know more about what it's doing than I do. So I'll stop since I don't have any more to add, unfortunately. Thanks, Max, for providing the link to the amlodipine and ADHD video. So Scooties 1983 was clarifying their question, which was, does amlodipine have any known benefits for the inattentive components of ADHD versus just the hyperactivity side? So the animal research was primarily looking at impulsivity and hyperactivity. The genetic complex Mendelian randomization study implicated calcium channel subunits as having some impact. So part of it was in that set of studies, the most simple, straightforward approach to figure out, does this work for humans with ADHD, wasn't done. They did not give, in a randomized controlled way, amlodipine to people and see what symptoms responded or not. What they did have is a database of people who were more likely to have ADHD based on their genome-wide analysis, based on a polygenic score. And they showed that there were two common symptoms of ADHD that were less present in that population than would be expected of those who are on amlodipine and not on other antihypertensive agents. And I'm not remembering what those two specific symptoms were, whether those were both in the hyperactivity impulsivity spectrum or whether one of them was an inattentive one. I'm just not remembering the details. But again, most of the research there is indirect rather than direct. And again, it would be fairly straightforward. I mean, if you go on Reddit, there are people on both sides saying, I've been on amlodipine and it didn't seem to have any impact on my ADHD. And there's others who are saying, yes, I've been on amlodipine and it helped with inattentive and hyperactive symptoms. So at least anecdotally, there are some claims that can help with both components of ADHD if this is even a meaningful way to split up ADHD symptoms. I mean, it's a conventional way. So thank you, Max, for providing the link to the Alcohol is Not Your Friend video. And I see we still have 10 minutes, so good. So James Alexander asks, what are some examples of your patients gaining awareness, more awareness regarding what was childhood abuse and neglect that you described earlier? One is there's a conundrum here that the more generic and less specific I am, one is probably gets less interesting, but two, then it also becomes more a fabrication in my mind of what's been learned rather than a specific anecdote or incident. On the other hand, since I don't have express permission from patients to be talking about their lives, and even if it's said anonymously or de-identified, some people feel that I'm talking about them, or maybe they were accurate and I was talking about them. Yeah. And to be, I mean, when I was answering your question earlier, it was aspects of my life that I probably normalized more than I should have, and it's only through more interaction with patients and seeing how some patients were traumatized by events that didn't seem that discrepant or dissimilar from what I had experienced that suggested that they may be having an impact on me. So I don't know if that made any sense. We can. So Max, thanks for providing the links to the PTSD and ADHD video and to the Calbri and ADHD video. And Max asks, why has lithium fallen out of favor in psychiatry? It seems to be one of the treatments with the biggest effect sizes, the most research, and one of the cheapest options. So cheapest options is, so the most conventional explanation is that lithium has been generic for decades. There are still some extended release and other formulations which are branded, but that means almost all of it is generic. Nobody's making a huge profit from it. I mean, it's cheap, therefore, no company has much benefit in promoting it to doctors or doing more study on it. So, two, particularly in bipolar disorder or as an adjunct for depression, those are its two most documented and extensive uses. Because of this, most of the data is considerably older, and there has been a trend to smaller effect sizes, larger placebo effects over time. There's debates over why that's going on, but it is possible that the appearance of bigger effect sizes is just an appearance rather than because these studies were done in a different era and there are not a lot of direct, for example, looking at it as a mood stabilizer. There's not a lot of studies that have a control arm, placebo group, lithium group, and a quetiapine group or a so there's very few head-to-head comparisons in the modern era. The third is that although lithium worked well, its rates of side effects are so the claim and most of the evidence suggests if you have full-blown bipolar 1 disorder, many people should stay on a mood stabilizer indefinitely because again, it doesn't just treat depression and mania, it prevents them. It only prevents it if you're taking it. And at doses that are therapeutic, and with lithium, there's pretty clear and robust evidence that if the levels are too low, you're not likely to be having much benefit. But at therapeutic doses, the likelihood of kidney damage after 20 years of being on it is something like a third of people are showing at least microscopic and early stages of kidney damage. That's really pretty high. Um, 1 out of 1,000 or more individuals right off the bat has autoimmune induced thyroid problems. That's not particularly rare. Can you argue that the thyroid is one of the glands or parts of the body that we can mostly replace pretty well for many people just taking it as a pill? Maybe, but who wants to be on a pill forever? And there's some people that are dosing with Synthroid and levothyroxine and just always seems to be slightly more poorly balanced than the brain was doing it itself to begin with. Um, and the third set of toxicity issues is that lithium is one of the drugs with one of the narrowest ranges of therapeutic to toxicity ratio. There's a more succinct term for that. And that is as little as 10 days of a therapeutic dose of lithium can be lethal. So, given this is a population more prone to suicidal ideation, that makes many doctors leery of prescribing lithium. Um, and I mean, that's not saying that 10 days is always a lethal dose, but it can be. It can also cause permanent neurologic problems. And lithium also, unlike almost all our other drugs, is entirely kidney dependent. So it's highly sensitive to fluid balance dehydration, particularly in a warming world where incidents of being dehydrated are more likely to occur. Lithium is problematic in that respect. So when it works, it's great, and it has its risks. So that's, and again, it doesn't have powerful champions now. And again, what I was saying earlier, doctors tend to be what they learn in residency training, sort of most intensively learning, stays with them. That doesn't mean they can't add new tricks, but given that lithium is not commonly currently the first choice drug for patients who are in the hospital. Oh, and the other monitoring thing is lithium, because of its risk, requires fairly regular blood testing. I'd say that's more both to check lithium levels and ascertain they're in a therapeutic level. So blood work and busyness, particularly as more and more doctors are doing telehealth medicine, that makes that type of monitoring more difficult and burdensome. So, so James Alexander asks, what are my current understanding mental framework of the relative importance and desirable levels of total cholesterol, HDL, and LDL? Um, I mean, my understanding is probably rudimentary. So I would say I'm just wasting your time if I'm telling you what I think, and probably Googling it is going to be more accurate in terms of the people, the endocrinologists and specialists who are looking at it can tell you about what's the, which is considered most important, or what cutoffs are worrisome and what cutoffs are only worrisome if you have additional other health factor risks. Um, so that's, I'll defer there because I do not think that I'm helping anyone by spouting my rudimentary or simplistic knowledge there. So Max, thanks, because yes, I completely did not see or read the question from Jack about how I would teach a nonverbal autistic child to speak. One, I'll just say that that feels outside of my wheelhouse. I will share that so often, I mean, the people who are most vocal on autistic issues, autism spectrum, are the people who are more towards, quote, the functional end of things rather than the severe end of things. Um, mm, um, yeah, I've I don't want to share too much anecdotally. I'll say when my kids were growing up and my kids had just finished college, one of our neighbors down the street with highly educated, very caring parents had two kids, one who was severely nonverbal and autistic, and I wasn't intimately involved in this kid's care, but I know they investigated a wide range of both medication and learning reprogramming approaches. And I never heard, and I don't think the child, or now a young adult, ever achieved more than simple grunts, and certainly expressive language was extremely limited. Their ability to understand and process speech was certainly better than their expressive speech. But to me, that would indicate that, and again, some of this is dated, but not that many years ago, someone with access to some of the best approaches and techniques at the most severe end of the spectrum, results were minimal. That certainly there's a wide variety within autism in terms of severity, but even in terms of responsivity at any degree or level of the spectrum. So that's where I'll stop on that one. So James Alexander asked, do I think that there are any negative side effects, especially kidney-related side effects from the daily dose of lithium you've described taking for protection against dementia? So usually to get a therapeutic blood level of lithium for bipolar disorder, the doses are, and again, it varies a lot, individual body size, other factors, but at least 600, usually closer to 9, 12, 15, 1800 milligrams a day. The doses of lithium orotate suggested for helping prevent dementia are in the 5 to 10 milligram range. So even the lowest dose of therapeutic is way higher than this. And again, the more recent studies by blanking Yankner at Harvard and his group suggested that there are different patterns of absorption within the brain or actions between different salts of lithium. So I am not the least bit worried of any risk for kidney effects at dosages this low. Again, these dosages are comparable to what individuals living in areas where there's high amounts of lithium rocks and leaching into the water and high amounts of high. Again, high is two orders of magnitude lower than therapeutic for bipolar disorder levels of lithium. And I'm not aware of any connection or evidence that in those populations there's higher rates of kidney problems. So thanks for showing up. Thanks, Max, for being here and providing good assistance with getting video links up quickly in a pertinent way and adding questions yourself. And Max also included a shout out to it's a general discussion about ADHD on the Struggle podcast with Gregor Thompson. So thanks for the good questions. And glad that our connection stayed good today. I'll be back. So in terms of daylight savings time, again, I'm sticking with a 10 a.m. West Coast US, 1 p.m. East Coast US. So I will be switching in my Hawaii time next week because Hawaii doesn't go on daylight savings time, but much of the rest of the US does. So anyway, be healthy, be happy. See you next week. Thanks for being here.